everyone, hope you're all doing good. In this video, we are going to continue with our discussion on disorders of sexual development. So let's discuss about XY DSDs. So this group is more diverse and heterogeneous group. Here the genital ambiguity is not seen. Okay, genital ambiguity is not seen. Okay, fine. Now let us discuss one by one. First one is pure gonadal dysgenesis. Pure gonadal dysgenesis, nothing but your Swyer syndrome. It is Swyer syndrome. So what happens in this syndrome? There is abnormality of the SRY gene, or there is loss of another gene that is necessary for the SRY protein action. Okay, so it's all depends upon SRY gene. Okay, so there is abnormality in the SRY gene itself. So there is abnormality in the SRY gene itself, or there is abnormality in another gene which is responsible for the SRY protein action. Clear? Right. So these people are phenotypically females. That means they will have normal Müllerian development. They will have bilateral streak gonads. It is usually present in adolescence with primary amenorrhea, or it can also present as delayed puberty, and here the testosterone levels are usually low. And how will you manage this condition? Yes, by doing hormonal therapy. You have to offer them gonadectomy. Okay, and you have to know this has to be done earlier because there is a high risk of malignancy in these people. About 35% risk of the testis getting testicular malignancy. Clear? Right. Now let us see the next syndrome, that is testicular regression syndrome. So it is testicular regression syndrome. So here we have a 46XY karyotype. Usually testicular regression happens within the first trimester. Okay, this happens within first trimester. This is also known as bilateral vanishing testis syndrome, where there is male sexual differentiation of duct and genitalia as well. So after this there is loss of testicular tissue. Okay, it can occur due to intrauterine torsion of the testis. The loss of testicular tissue can occur due to torsion. And if you see these people, they are phenotypically males who have an isolated micropenis Remember, it is micropenis. Then there can be absent or present of streak gonads. There can be low testosterone, and because they have streak gonads, obviously the gonadotropins in them are going to be high, right? So there is elevated follicle stimulating hormone and luteinizing hormone levels. Okay. So how you are going to manage these patients? Management in these patients is usually done by testosterone replacement therapy, that is done during puberty. Clear? Right. Now, the next disorder we are going to discuss is ovotesticular disorder of sexual differentiation. So, this ovotesticular disorder of sexual differentiation. Actually, this is one of the rare presentation of sexual differentiation disorder. So, it is rare. Why it is ovotesticular means? Because it will have the ovarian tissue with the follicles as well as the testicular tissue with the tubules in the same individual. Okay. Here the karyotype will be 46XX in 60% of the people and 46XY in 15% of the people, and it can be due to mosaicism in 25% of the cases. Clear? Right. Now let us see how the gonadal combination can be. So there can be different types of gonad combination that can exist in these people, which will include ovotestis one side and other side it can be a normal ovary, and the second combination is ovotestis itself, that is in one gonad you have both ovarian and testicular tissue, that is ovotestis, right? And the third combination can be ovotestis or otherwise one side they can have a normal ovary and the other side they will have a normal testis. So these are the various gonadal combination in ovotesticular disorder of sexual differentiation. Clear? Right. Now, in most of the people, uterus is seen and the ovary is going to be normal, whereas the testis is dysgenetic. Okay. So let's see how they will be presented. So presentation of ovotesticular disorder means, yes, definitely they will have a genital ambiguity. Then they will present with masculinization, and third point is that they can present with inguinal hernia. The component is nothing but the gonads. Okay. Now let's see how will you assign the gender for these people. So gender assignment in these people, it is usually individualized. Okay, this is usually individualized based on the external genitalia, their hormonal profile and response to HCG like. Okay, so in these people you have to offer a surgical treatment for removal of the gonads which are discordant, right? So removal of the discordant gonads, as well as you can even offer them hormonal therapy. Okay. Oh. Now let's see the next disorder, that is LH receptor So, what is this LH receptor defect? See, the testicular Leydig cells of an XY individual becomes insensitive. Okay, these cells become insensitive for the production of testosterone. Okay, so this is similar to complete androgen insensitivity somehow. Okay, so what is happening here is there is deviation of androgens to estrogen pathway. Okay, so this pathway is not going to happen normally in these people. So, there is no subsequent breast development. Clear? Fine. Now, let us discuss about the biggest group in this set, that is androgen insensitivity syndrome. Okay. So, we are going to discuss about androgen insensitivity syndrome. We have two main types here. One is complete androgen insensitivity syndrome. Another one is partial androgen insensitivity syndrome. So, what is androgen insensitivity syndrome as such? There is resistance of the androgen receptor. Okay, or its mediators as well for the binding of testosterone as well as dihydrotestosterone also, that will be resulting in androgen insensitivity syndrome. So, basically in simple words, it is a receptor defect of the androgen. Okay, right. So, we have something called as complete androgen insensitivity syndrome. Here the karyotype is going to be XY and the gonads are testis. Okay. So, what happens here? The Müllerian structures regress because AMH hormone is acting. Okay, so under the action of anti-Müllerian hormone, Müllerian structures are going to regress. Clear? And the next one is, in the suppose if there is a minimal testosterone action, also, the Wolffian ducts will be maintained. Okay. So, what are the two important points we have learned here? Number one, Müllerian structures are going to regress under the action of anti-Müllerian hormone, but there can be a minimal testosterone action present in some people. In that case, Wolffian ducts will be maintained. So, at birth, what happens? External genitalia appears like a female because there is absence of action of the dihydrotestosterone hormone also. So, this is responsible for the external genitalia development. So, at birth, external genitalia will be seen like a female because there is no dihydrotestosterone hormone action. Okay, and then breasts usually develop normally because the testosterone, whatever is present, it is not acting on the androgen receptor only, but the mechanism of conversion of testosterone into estrogen by the enzyme, yes, very good, aromatase is going to happen. Clear? And what happens during puberty in these cases? So, during puberty, the phenotype is going to be, yes, very good, they are going to be female with normal breast development. Then they will be presenting to you with primary amenorrhea. Testosterone action is hindered by the receptor defect. So, there is scanty pubic and axillary hair and then they can even have bilateral inguinal hernias. Okay, that is nothing but the undescended testes. Okay, so this is all you have to know. Okay, so the gender of these people will be assigned like a female usually, and they will be reared like a female. Okay, now let's discuss about partial androgen insensitivity syndrome. So it is partial androgen insensitivity syndrome, that is I am mentioning it as PIS. Okay, so in these people the karyotype is going to be XY, the gonads are going to be testes, and here also the Müllerian structures are going to regress under the action of anti-Müllerian hormone, and then the different degrees of insensitivity is seen. Okay, that means there will be varying development of Wolffian ducts. Okay, clear? So because insensitivity means insensitivity to the hormone testosterone. Okay, so some parts of the duct may develop normally, some parts may not develop normally, like that, right? Fine. Now how will be the appearance? Appearance of the external genitalia can be variable, but hypospadias is also common, and these people are reared like a male usually. Okay, so management of these people will usually consist of hormonal therapy and then post pubertal gonadectomy. Clear? Right. Now let's discuss about one special set. This can be considered as a category of androgen insensitivity syndrome also, because here there is 5-alpha reductase deficiency. This enzyme is involved in the conversion of testosterone to dihydrotestosterone. Okay, and here I am discussing it separately here. Okay, it is 5-alpha reductase deficiency. So here there is a disruption of final pathway of androgen synthesis in the testis. 5-alpha reductase, as I told you, it is going to be involved in the process of conversion of testosterone to dihydrotestosterone. Okay, so this deficiency is usually inherited as an autosomal recessive pattern, and presentation in these people will be like they will be having variable genital ambiguity. They can be having a complete female phenotype. They can have a short blind vagina, and during puberty they can present with features of partial masculinization or body habitus just like a male, and there can be increased phallic size also. Okay. So, how you will be diagnosing this condition? So, diagnosis usually depends upon the detection of normal gonadotropins. At the same time, you will have an abnormally high level of testosterone to dihydrotestosterone ratio. Okay, this will be more than 20:1. Clear? Now, let us see the surgical management. So, surgically, these patients can be treated with gonadectomy, vaginoplasty, clitoral reduction, and they can be given hormonal therapy as well. Clear? Right. Now, let us discuss about the disorder of AMH receptor. Okay. So, disorder of AMH receptor. So, this is nothing but a persistent Müllerian duct syndrome, okay, which has an autosomal recessive trait, and these people usually don't have genital ambiguity. They are usually phenotypic males with cryptorchidism and abnormal Müllerian structures. These people are usually managed surgically. Clear? Right. So, here I want to give you an idea on how to come to a diagnosis of 46XY disorders of sexual differentiation. Okay. So, if you have 46XY genotype, you have to check whether the gonads are present or absent. Say the gonads are absent. If the gonads are absent, then you have to check for the presence of uterus. Okay. You have to check whether the uterus is present or absent. Okay. Based upon this, when gonads are absent means that is going to be testicular regression syndrome irrespective of the presence or absence of the uterus. Okay. So, that is going to be a testicular regression syndrome. Clear? Right. Now, suppose let us keep that the gonads are present. Okay, gonads are present. Then what happens? You have to see what type of gonad it is. Yes, the gonads can be a ovotestis or it can be a dysgenetic gonad. I am just writing D here, or it can be streak gonads. I am writing yes, and then the next can be two normal testes. Okay, so two testes which are normal. Clear? So that means when ovotestis is present, yes, in the next step you have to see whether the uterus is present or not. If the uterus is present or not, based upon this we have to check. Okay, so uterus can be present or absent in an ovotesticular disorder. That means here it can be a ovotesticular disorder of sexual differentiation. Okay, this is a ovotesticular DSD. When they have dysgenetic gonads, you have to check how about the uterus. Then based upon this, you will be giving a diagnosis of partial gonadal dysgenesis. Clear? And when they are streak gonads and you have the uterus, okay, uterus or present means this is going to be a case of complete gonadal dysgenesis. And when you have two testes, okay, two testes which is normal, and then you see the uterus is absent, then this is going to be a disorder of androgen insensitivity syndrome. Okay. So this is how the diagnosis will be made. Okay. So once again I will tell you, when you have a 46XY genotype, you have to check whether the gonads are present or absent. When the gonads are absent, even when a uterus is present or absent, you don't consider this. When the gonads are absent, then you have to name them as a testicular regression disorder, right? Then if the gonads are present, you should know what type of gonads are present. It can be ovotestis, or it can be a dysgenetic gonad, or it can be a streak gonad, or it can be two normal testes also. So based upon this, you have to decide the diagnosis, but before this you have to check the uterus present or absent also. In ovotesticular disorder and dysgenetic gonads, the uterus can be present or absent, whereas in a streak gonads, the uterus is definitely going to be present, and when you have two testes, yes, definitely the uterus is going to be absent. So depending upon that, you will be giving a diagnosis of ovotesticular DSD, partial and complete gonadal dysgenesis, and androgen insensitivity syndrome, right? Let's discuss now about the 46XX disorders of sexual development. Okay. So 46XX DSDs. Clear? First, let us discuss about the testicular DSD. Testicular DSD, here the chromosomal pattern is going to be 46XX only, and here you have two types of testicular DSD. Okay. Number 1 is SRY positive type, which is going to constitute more than 80% of the cases. Here you have a translocated copy of SRY gene in X chromosome, that is paternal X chromosome. Okay, there is a translocated copy of SRY gene. Okay, and the next one is SRY gene is negative. Either the SRY gene is positive or otherwise the SRY gene is negative. What happens when SRY gene is present, how it is going to be present in a 46XX individual means there is a translocated copy of SRY gene from the paternal X chromosome. Can you understand? So that's why the group is 46XX DSD, but the name is testicular DSD. Can you understand? Yes, right. Next one, let us see how the phenotype of these people will be. So phenotype is going to be male phenotype. These people are usually short, having gynecomastia and male genitalia. They usually have small testes, and because of them, yeah, definitely they will be infertile with azoospermia. They will have low testosterone levels. There is increased luteinizing hormone and follicle stimulating hormone. Clear? Now let us see the management. Management of these people is going to be with androgen replacement, and then you have to give them a reduction mammoplasty. Clear? Right. Next one, let's discuss about congenital adrenal hyperplasia. Okay, it's going to be congenital adrenal hyperplasia. Okay, so congenital adrenal hyperplasia is an autosomal recessive disorder. Okay, here you have enzyme deficiency. Okay, enzyme deficiency can be complete or partial. that is responsible for what enzymes means? The enzymes that are responsible for the synthesis of cortisol or aldosterone synthesis in the adrenal gland. Okay, and this is the most common cause of excess type of disorder of sexual differentiation, and this accounts for 50% cases with ambiguous genitalia as well. Clear? And also remember, it contributes 1% of cases to primary amenorrhea and also 0.5% of the cases to cases of secondary amenorrhea as well, especially when they have a late onset of congenital adrenal hyperplasia. Okay, the incidence of this condition is going to lie between 1:10,000 to 1:20,000 live births. Clear? Right. Now let's see what are the various forms they can present with. Okay, you have 3 clinical forms of presentation. Number 1 is salt wasting type of congenital adrenal hyperplasia. This is going to constitute about 75% of the cases. Here there is a deficiency of 21 hydroxylase. There is 21 hydroxylase deficiency. Okay. So what are the features of this deficiency? So this is usually a life-threatening condition that is presenting with salt losing crisis. Second one, at birth these people will have ambiguous genitalia. They will present with salt losing crisis, especially in the first to second week of life. Okay, week of life. That means there will be hyponatremic dehydration. There will be progressive weight loss also. Clear? Right. So these are the features of 21 hydroxylase deficiency. This is a life-threatening condition. At birth, they will be presenting with ambiguous genitalia and they will be presenting with salt-losing crisis in the first and second week of life, and that will be presenting with hyponatremic dehydration, and they will be having progressive weight loss also, right? Yes. Now, let's see the second type, which is a simple virilizing type of congenital adrenal hyperplasia. And this is what I mentioned as a cause of secondary amenorrhea, that is nothing but a late onset or adult onset of congenital adrenal hyperplasia. The incidence of this type of congenital adrenal hyperplasia will be seen in 1 in 30. So they usually have normal genitalia at birth. Onset of virilization is usually seen at puberty, and in these people the bone age is more advanced. Clear? Yes. Let's discuss about the other type of CH, which is nothing but non-classic congenital adrenal hyperplasia. Okay. In this type, there is no salt wasting or there is no virilization as well, which we have seen in the previous 2 cases. Okay. So, let's discuss about the pathophysiology of this condition. Pathophysiology of congenital adrenal hyperplasia starts from ACTH, which will be acting upon the adrenal gland, and this influences the production of cortisol and adrenal androgens. Okay. Now, let's see this process in detail. So, this is a flowchart that is depicting how the steroid hormone synthesis is happening. What is exactly happening in the adrenals? Okay. So, it all starts with the cholesterol, which will be converted into pregnenolone by the enzyme 17-alpha hydroxylase, and that will be converted into progesterone by the enzyme 3-beta hydroxysteroid dehydrogenase, and then it will be converted by 21-alpha hydroxylase into deoxycorticosterone, which will be acted upon by 11-beta hydroxylase to corticosterone, and corticosterone will be acted upon by 18-hydroxylase to convert into aldosterone, okay, and we will be getting the mineralocorticoid. This is one type. Again, the pregnenolone here will be acted upon by the 17-alpha hydroxylase, and progesterone will also be acted upon by 17-alpha hydroxylase. From pregnenolone, we will be getting 17-hydroxypregnenolone, and from progesterone, we will be getting 17-hydroxyprogesterone. That will be having the action, like the conversion among them also happens like same in the first step, that is 3-beta hydroxysteroid dehydrogenase and 21-alpha hydroxylase. Then it will be converted into 11-deoxycorticosteroid, cortisol, that will be acted upon by 11-beta hydroxylase, and then you will be getting cortisol, which is a glucocorticoid. Okay. Now here 11-hydroxypregnenolone will be converted into dehydroxyepiandrosterone, okay, that is DHEA, that will be acted upon by 3-beta hydroxysteroid dehydrogenase, that will be converted into androstenedione, and testosterone. Testosterone will be acted upon by 5-alpha reductase to converted into dihydrotestosterone, and sometimes androstenedione will be converted into estrone and estradiol also. Okay. So, dihydrotestosterone will also be converted into dehydroepiandrosterone sulfate. So, these are the sex steroids we will be getting. Okay. So, the testosterone, estrone, estradiol, androstenedione, all these are sex steroids. Okay. So, this flowchart is very important, and the precursor for all these synthesis of mineralocorticoid, glucocorticoid or sex steroids is nothing but the cholesterol, and the hormones will be going like this. Okay. So, it is 3, 21, 11 and 18. Okay. 3, 21, 11 and 18. 3-beta hydroxysteroid dehydrogenase, 21-alpha hydroxylase, 11-beta hydroxylase and 18-hydroxylase. I hope this flowchart is clear for you, and you have to know this flowchart clearly so that you will be understanding how congenital adrenal hyperplasia pathophysiology is going to be there. Okay. So, what happens means, so if there is enzyme deficiency in any of this pathway, that will usually result in deficiency of cortisol, and because of that ACTH will increase, that will be causing adrenal hyperplasia. Because of adrenal hyperplasia, there can be increased steroids or increased androgens as well, that will be resulting in virilization. Okay. The most common enzyme deficiency is going to be 21-alpha hydroxylase deficiency, which will be constituting about 90% of the cases. Okay. Other deficiencies can also include 11-beta hydroxylase deficiency, which will be constituting about 5 to 8% of the cases, and then 3-beta hydroxysteroid dehydrogenase deficiency also, which is a very rare disorder. Clear? Right. Now, let us see what are the investigations we can offer these people. Okay. So, investigations, whenever you see these people, there will be elevated levels of serum 17-alpha hydroxyprogesterone. This is going to be a diagnostic marker for congenital adrenal hyperplasia, very important. Okay. So, if you measure these levels and the levels are going to be less than 200 nanogram per deciliter, then it is considered normal. If it is going to lie between 200 to 800 nanogram per deciliter, then you have to offer them ACTH stimulation test, which will be followed by, in which you will be giving 250 microgram of synthetic ACTH, that is given as an IV injection, and after 1 hour of this you will be measuring 17 alpha hydroxy progesterone, and if it has risen above 1500 nanogram per deciliter, it is diagnostic. Okay. So, we can even have two types of congenital adrenal hyperplasia. One can be classic one, and there is also a non-classic type of congenital adrenal hyperplasia. I will explain it soon. But remember, for the classic types where there is enzyme deficiency, this value can even go above 10,000. Okay. For the non-classic types, this value will be usually lying between 1000 to 10,000. Okay. So, this is going to be a classic type and this is going to be a non-classic type. Clear? And whenever you measure 17 hydroxylase progesterone and the levels are seen above 1000 nanogram per deciliter in the starting itself, then these are going to be diagnostic of congenital adrenal hyperplasia. Clear? Now, let us see the next one. So, 24-hour urinary excretion of pregnenolone triol as well as alpha ketosteroid can also be seen where it will be increased in these conditions. Clear? And the next investigation is doing your USG to check whether the uterus, tubes, ovary and vagina are present or not. And karyotype usually in these patients will be 46XX. You can even offer them a prenatal diagnosis by amniocentesis to measure 17 hydroxylase progesterone. Also, you can do HLA typing of the amniotic cell. Sometimes you can even offer them chorionic villus sampling. Clear? Let us discuss about the non-classic congenital adrenal hyperplasia. Okay. So, non-classic congenital adrenal hyperplasia, this is also known as lipoid congenital adrenal hyperplasia. Here there are mutations in star gene. Okay. Star gene means that is nothing but steroidogenic acute regulatory protein. Okay. And some suggest there is defect in the cholesterol transport. There can be complete deficiency of glucocorticoids, mineralocorticoids as well as sex steroids, because the cholesterol to pregnenolone transformation is there is a defect. Okay. So, because of this all these can be affected, and in XY patients complete sex reversal, severe adrenal crisis, and you will also see significantly enlarged thyroid gland. Okay. Fine. Now, let me give a differentiation between the 4 types of important types of congenital adrenal hyperplasia, that is 21 alpha hydroxylase deficiency, 11 hydroxylase deficiency, 3 beta hydroxysteroid dehydrogenase deficiency, and the non-classic type we have just discussed. So, this will be giving you an overall picture of congenital adrenal hyperplasia, right? So, let us see, it is 21 hydroxylase deficiency or 11 beta hydroxylase deficiency, 3 beta hydroxysteroid dehydrogenase deficiency, and 4th type, that is the non-classic type, it is also called as lipoid congenital adrenal hyperplasia. Okay, the features we are going to discuss in all these 4 types include your genitalia. Okay, what about your glucocorticoids? I am writing G only, but it is glucocorticoids, your mineralocorticoids, and about your androgens. What about your sodium, potassium, and the metabolite, that is elevated. Okay, metabolite elevated. Okay, so these are the things we are going to discuss. Let me write it completely. So it is glucocorticoids, mineralocorticoids, and androgens. Clear? Now, in 21 hydroxylase deficiency or any other type of congenital adrenal hyperplasia, your genitalia is going to be ambiguous genitalia. Okay, yes, it is completely ambiguous genitalia only. But remember, when you do a karyotype in 21 hydroxylase, 11 beta hydroxylase, the karyotype will be XX. Okay, whereas in 3 beta hydroxysteroid dehydrogenase and lipoid dehydrogenase, the karyotyping will be XY. Clear? Let's discuss about the glucocorticoids. In 21 hydroxylase deficiency or any other conditions, congenital adrenal hyperplasia, there will be reduced glucocorticoids. Okay, whereas mineralocorticoids are increased in 11 beta hydroxylase deficiency alone. Okay, but in other conditions, it is going to be reduced. Okay, so let me give it with a warning so that you will understand. Okay, so here it is going to be increased, whereas in other conditions this is going to be reduced. Clear? And then let's see about the androgens. Androgens are increased in 21 hydroxylase deficiency, 11 beta hydroxylase deficiency, and in 3 beta hydroxysteroid deficiency, the androgens can be increased or reduced. Okay, because in 3 beta hydroxysteroid deficiency, it can happen in either way. That one you have to remember. And in lipoid type of congenital adrenal hyperplasia, it is going to be reduced. Clear? The sodium content in 21 alpha hydroxylase deficiency is going to be reduced, whereas it is going to be increased in the case of 11 beta hydroxylase deficiency, and in the other 2 conditions also the sodium content is going to be reduced. Okay, and finally the potassium, if you see, it is going to be increased in a case of 21 hydroxylase deficiency and 3 beta hydroxysteroid deficiency, whereas it is going to be reduced in case of 11 beta hydroxylase deficiency and lipoid type of CH. So the metabolic defect is that is elevated includes 17 alpha hydroxylase progesterone in case of 21 hydroxylase deficiency, and in 11 beta hydroxylase deficiency you will have the 11 deoxycortisone to be elevated, and here in 3 beta hydroxysteroid deficiency it is dehydroxyepiandrosterone that is elevated, and in lipoid deficiency there is nothing like that. Okay, so this is the table you have to remember. Okay, so since 21 hydroxylase is the major type of CAH in the diagnosis, I especially mentioned about the investigation to do 17 hydroxy progesterone. Clear? Right. Now let's discuss how will you manage this condition. So management, when there is salt wasting crisis, you have to offer them fluid and electrolyte balance. Then there should be replacement of cortisol deficiency with deoxycorticosterone. The next one is they are usually reared as females. So, you have to offer them clitoroplasty if they have an enlarged clitoris, and also vaginal reconstruction can be offered. So, in these women, menstruation occurs, so coitus is possible and pregnancy is also possible. That one you have to understand. Okay. And finally, don't ever forget about bilateral adrenalectomy. Okay, if there is failed medical management, especially in adult females, if they want to plan on fertility as well as they have a salt wasting type of congenital adrenal hyperplasia. Okay, so I hope congenital adrenal hyperplasia is clear for you. Now let's summarize how to come to a diagnosis with a person who is having 46XX disorders of sexual development. Okay, so 46XX DSD means you have to check their gonad. They can have a ovotestis or two normal testes or two streak gonads or two ovaries. Clear? When they have ovotestis, you have to check whether the uterus is present or not. Uterus is present means it is going to be ovotesticular disorder of sexual development, and if they have two testes, then the uterus is present or absent. You have to see mostly when they have testes, yes, uterus is going to be absent. So, in that case, this is going to be testicular XX testicular disorder of sexual development, and when they have two streak gonads, this is going to be having uterus definitely. Okay, they will have uterus definitely, and this is going to be a case of, yes, gonadal dysgenesis. And when two ovaries are present, definitely the uterus will be present, and if she is a virilized female, you have to check for 17-hydroxyprogesterone levels. If the 17-hydroxyprogesterone levels are low, then it is going to be a non-classic type of congenital adrenal hyperplasia, and suppose if these levels are high, then they are going to be a classic type of congenital adrenal hyperplasia. Okay. So, this is how you come to a diagnosis with 46XX disorder of sexual development. I will repeat it once again. You have to check the gonads directly when it is 46XX. If it is going to be ovotestis and uterus is present, whether uterus is present or not, when it is ovotestis, we will be naming it as ovotesticular DSD. When you have testis, definitely uterus is not going to be present. That means it is a testicular DSD. Okay, but the chromosome is XX. Okay, I told you why it is a testicular name is given here and why it is coming under this category 46XX, right? Then when you have two streak gonads, definitely you will have the uterus. This will be a case of gonadal dysgenesis. And when you have two ovaries, definitely uterus will be present. When uterus is present and the female is virilized, you have to check the 17-hydroxyprogesterone levels, and depending upon the value of 17-hydroxyprogesterone, you will be classifying it as classic and non-classic type of congenital adrenal hyperplasia. I hope disorders of sexual development is done in detail with you. I hope you understood the topic as well. So, until we meet in the next video, take care, happy learning, keep going, and bye-bye.